Welcome to the American Shoulder and Elbow Surgeons Podcast. I'm your co-host, Peter Chalmers, a shoulder and elbow surgeon at the University of Utah, and I'm fortunate to have Brian Waterman, a sports and shoulder surgeon at Wake Forest, as my co-host. Brian, how are you?
Hey, good morning, Peter. How are you?
Oh, I'm doing great. Before we get started, I should mention the views expressed in this podcast do not necessarily reflect the views of the American Shoulder and Elbow Surgeons, the University of Utah, the Wake Forest University, or the institutions of our guests. So today we're very excited to invite Dr. Bassem ElHassan on the podcast as our guest. Bassem is the chief of shoulder surgery at Mass General Hospital in Boston, and he's a true pioneer and innovator. So we've previously had him on to discuss his background in lower trapezius transfer, which has become widely adopted in the treatment of irreparable posterior superior rotator cuff tears. We want to have him back on to talk about all the other great things that he's done, particularly talk about his approach to the scapula, which I think has really changed a lot of our understanding. Welcome to the podcast, Bassem.
Good morning. Thank you. I'm glad to be here.
Well, we're very excited to have you. So, I had previously had you on. You and I had sat in a hotel room in Nice, and you'd gone through your background, and it was amazing. And we talked about the lower trapezius transfer, but we had so much content, we really didn't get a chance at that point to discuss all the other contributions you've made to our understanding of the scapula and the tendon transfers. And I wanted to talk a little bit about those. So I want to start with the evaluation. So a patient comes to your clinic and you suspect a periscapular issue. Tell us, what does your examination look like? How do you assess that patient, kind of before we get to the imaging and the diagnoses? Like, how do you, from the ground up, talk to that patient and look at them?
Well, as shoulder surgeons, we are used always to look at the shoulder, and the definition of the shoulder in general is the glenohumeral joint, which is the ball and socket, the deltoid, rotator cuff. However, in reality, the shoulder is the scapula. So no matter what, when the patient comes and they have certain problem around the shoulder area, I usually always teach the resident and fellows to make sure to inspect, take a look, get used to what is a normal anatomy and what's not in terms of alignment, posture, comparing the normal to the abnormal side, inspection, and go through like the process of course, like step-by-step examination. But truly, it takes time to kind of truly understand the scapula if someone does not spend time to try to see what's normal and how it looks and how it appears. So it's the first steps into the exam is the very basic that's taught in medical school, it's taught in any basic, when we talk about examination, is inspection. Inspection, look, appearance, normal, what's abnormal, and then we'll go through the exam.
Yeah, that's great, Bassem. I agree. The nuanced exam, both standing supine, looking at postural control, making sure you're really truly visualizing all those key subcutaneous structures is key. And I think that often gets short-sheeted a little bit. The other thing that we commonly see that doesn't get much airplay is imaging around the scapula. This is very challenging. I'm wondering, what do you use as a matter of routine? Is there ultrasound? Is there some other routine imaging that informs your approach to this?
Well, yes, there are some routines, but like the first question was, I feel, the most important question because 80 to 90% of the pathologies around the scapula that we see, the imaging, when you take them, they're usually normal. And we're going to go through the imaging, but this is why the first step of like inspecting, examining is the absolute most important steps. Basics, just to make sure, number one, no gross bony abnormalities. You can get basic x-rays for the scapula with the shoulder, making sure the shoulder girdle is included, which is like three joint, one articulation, glenohumeral AC, SC joint, and scapulothoracic articulation. Most of the time, these are preserved, most of the time. And then you go from the x-ray into more advanced imaging, depending on the symptoms, depending on what you determine on examination. But I can tell you, more than 90% of the time, the diagnosis is by physical examination.
Yeah, yeah. I mean, that's great, and you certainly have innovated in this space, looking at scapulothoracic abnormalities and movement, or STAM, as you've kind of truncated that. And let's dive in on some of the ultimate etiologies here. So let's start with spinal accessory nerve palsies. I know you've developed a novel transfer, the triple transfer. Can you tell us a little bit about this and how you developed this technique?
Yeah, absolutely. But again, let's make it more because especially this is an audio kind of interview for whoever gonna be listening to it, just to have the bigger picture. So anytime patients come with abnormality around the scapula, we call it STAM, scapulothoracic abnormal motion, which is essentially the English translation of dyskinesia. But I changed it because the definition, it has been very confusing for me. What is exactly dyskinesia? What's exactly winging? So this is why we changed it to STAM. And with the STAM, whenever you see a patient coming with abnormal motion, STAM, I always tell the resident fellows and myself and the patients, we have two big categories: structural, functional. Structural, we know it. When we talk about shoulder, let's say itself, talk about rotator cuff, labrum, fracture, nerve. This is structure, something structurally abnormal. And functional, when the muscles, each muscle is working okay, but together they're not working okay. Okay, we call it functional. Now we go back to your question. Under structural, you can have muscle problem, you can have bony problem, you can have both. Under muscle problems, usually almost always, you have three categories: trapezius paralysis, serratus paralysis, or combined. Now, each one of these is treated differently. We always try to mimic the muscle that's paralyzed by transferring muscles similar to it to mimic the function. So with trapezius paralysis, from where the origin is and the insertion is, from the neck to the scapula, what are the muscles close to that muscle? Levator scapulae, rhomboid minor, and rhomboid major. So these muscles originate very similar almost from the spine, cervical, upper thoracic, and insert on the scapula on the medial side. The trapezius originate from the cervical, thoracic, and go into the spine of the scapula and the acromion. So when we have trapezius paralysis, which is a structural muscular dysfunction, we do the triple muscle transfer, which is essentially transferring the levator scapulae, the rhomboid minor, the rhomboid major, from their insertion on the inner part of the scapula to attaching them on the outer part, which is very similar to the attachment of the trapezius, mimicking the function of the trapezius. This is what we call the triple muscle transfer.
Yeah, that is one of the cleanest explanations for scapulothoracic external motion I've ever heard. So thank you for that, because I think listeners alone, if they could just take that out, will really find that helpful. I think that you've undersold, that makes perfect sense. You take those muscles from the medial border, you transfer to the spine and the acromion, but it's more than that too, because you're also transferring a little bit of bone, you're transferring it onto bone through drill tunnels. So there's also biomechanical reasons why this might be better than the traditional kind of Eden Lang, where you just take those muscles and move them medially.
That's correct. This is, but again, here where we're talking about, we're going into layers right now. We're talking from principle, pathology, treatment, and when we go into the treatment, even the depth of the treatment, and that's your question right now, because the traditional, first of all, these three muscles, whenever we transfer muscles, and I'm hoping the audience, what muscle transfer is, we're talking about moving the tendon that's attached to the muscle from one place to another place. And patients sometimes say, do I have muscle transfer or I have a tendon transfer? Well, we call it muscle transfer, but realistically, we're transferring the attachment, the tendinous attachment of the muscle from one place to another place, which means moving the muscle with its tendon from place to place. Now, there are certain muscles in the body, they don't have barely any tendon. And these three muscles, the levator, scapular, rhomboid minor, rhomboid major, they barely have any tendinous attachment, which means if we want to detach them without bone, to attach them on bone, the likelihood for failure will be high. In order to make the healing rate much better, we take them with a piece of bones. The traditional needle neck procedure, they transfer the levator scapulae from the medial side of the scapula to the mid-spine, and they take the rhomboid minor or rhomboid major wherever they were, and they just advance them laterally. Biomechanically, this makes no sense at all. Why? Because the trapezius attach on clavicle, acromion, spine. It does not attach on the body of the scapula. So this, by principle, is not correct. And when we talk about the mobility of the scapula, if we consider external rotation, it means the scapula is sliding on the chest as you're taking your arm in abduction. So it's sliding in external rotation. The distal scapula going away from the spine, this we call it external rotation. And internal rotation, the distal scapula coming close to the spine. So when you lateralize the rhomboid minor, rhomboid major on the body of the scapula, they can potentially, paradoxically, cause more internal rotation of the scapula, which means the motion that you want to recreate, which is the abduction of the shoulder, could be counteracted by this muscle being advanced laterally. For this reason, the triple transfer biomechanically, anatomically is much better, because individually you're transferring these muscles on the lateral spine and medial spine of the scapula, which is the majority of the attachment of the trapezius.
Okay, so that's the lateral winging patient, or the patient who structurally has winging because of loss of the trapezius. Tell us about the other piece here, the medial winging patient, the patient who has structural scapulothoracic abnormal because of loss of the serratus.
Okay, so, and again, Peter, like with this one, please accept this from me. For my fellows and residents, they're not allowed to talk about medial and lateral winging anymore. The only way they can talk about it if they can explain it to me very well. They tell me, oh yeah, this patient has lateral winging. Okay, what do you mean? Oh, trapezius paralysis. No, this is not the explanation of lateral winging. What do you mean by lateral winging? Yeah, I meant trapezius paralysis. Okay, what's medial winging? Oh, serratus paralysis. Explain it to me. What does it mean, medial? Do you mean like lateral? It means lateral border of the scapula winging out? Or you mean the medial border winging out? And I promise you, over the years, not a single one explained it very well. And for this reason, I told them, yes, like for someone like you who understands scapula very well, if you want to mention it, I'm okay completely with it. But anyone who wants to mention it, they have to mention it with explanation how, not because you have that muscle paralysis. So anyway, when you have a trapezius paralysis, the scapula in general does not wing off the chest wall. What happened, the scapula droop down. It will have a drooping down. There might be some prominence of the scapula, but during motion, you don't see much prominence. When you have serratus paralysis, which is the other part, because you have the two major muscles controlling the scapula are the trapezius and the serratus. And the serratus is a huge muscle on the chest that controls the inner part of the scapula and keep it on the chest wall. Because it keeps it on the chest wall, this is why when it gets paralyzed, the scapula stick out big time. This is a true quote-unquote winging. So when you say a big time winging, in general, either serratus or combined, not as much trapezius paralysis. So trapezius goes drooping with an anterior tilt of the scapula. When you look at the scapula, it looks like truly drooped down. Rather than you seeing big time the scapula sticking off the chest to define quote-unquote winging. But when you have serratus paralysis, then during motion, that stabilization effect of the serratus on the chest will go away. So when the patients want to raise their arm, the scapula goes away from the chest and wing big time. So in the setting of, for this one, we have more traditional treatment that was described before. It's not my description. Maybe I did modification of the technique. which is the transferring of the sternal head of the pectoralis major to the distal scapula. So any of the tendon transfer we do, we essentially mimicking the muscle that's gone with another muscle similar in terms of tension, line of pull, vector. And if we look at the anatomy of the serratus originating from the mid thoracic area and going to the scapula, the pectoralis major coming from the medial thoracic area, but going to the humerus. So if we change that attachment of the pectoralis from the humerus to the distal scapula, we can mimic very well the most important portion of the serratus, which is the distal serratus. So the transfer of the sternal head of the pectoralis to the distal scapula is an excellent transfer in the patient who have stem structural from the paralysis of the serratus to reconstruct the function. And the only technique, like the only thing modification we did, again, because I like the bony insertion, even though the pectoralis has a nice tendon, usually we detach it with piece of bone and we do a bone-to-bone attachment because the healing will be much better.
Awesome. I wanted to backtrack a minute and just talk about the simple concept of nerve decompression. We're talking about a lot of these ways that we can readdress some of these abnormalities of movement through muscle and tendon transfer. What, if any, is there a role for nerve decompression, most specifically about the spinal accessory nerve? I remember in fellowship doing a small number of these, but have never been able to really follow these out to have any sort of comparison in terms of function. Can you share your experience briefly?
Yeah, sure. So this is like a truly relatively bigger topic. So if we're talking about nerve disorder causing muscular disorder, we're talking about the true structural again, which means nerve is affected, causing the muscle to be weak, to cause the abnormality around the scapula. This is one category. The other category is you have in carpal tunnel. Many times the patient have numbness and pain, no weakness, and sometimes they have weakness. So, or you can have compression on some of these nerves that can cause pain. They can cause functional stem because of the pain, not necessarily like the serratus paralysis or trapezius paralysis. This is a different category. We do a fair number of these depending on the category. So what does this mean? Let's take it, the one which is relatively more common. If you have, let's say you talk about spinal accessory, I'm going to talk about long thoracic, we can talk about spinal accessory as well. But because the serratus is big muscle on the chest, the long thoracic is exposed, you can get trauma, you can have Parsonage-Turner syndrome, which is the inflammation of the nerve, and they end up having long thoracic nerve palsy that usually recovers based on data within a year or two. But some of these patients, the recovery is very slow. You don't feel like their muscle is waking up. There is no nerve lesion. There's no injury, true injury, but could potentially kind of what we call a double crush phenomenon, where the inflammation with some of the normal facial covering of this nerve, this combination can cause the nerve to shut down and the muscle is not working very well. With these patients, we can do two things. One, arthroscopic, we release the nerve because you don't have to do any big opening. You can see the nerve all the way from proximal to distal arthroscopically, and you can release it fully. The main reason for the release is just to release any facial covering that in normal case may not cause major problem, but in someone who has inflammation may cause problem. That's number one. Number two, we release the pectoralis minor at the same time because these patients adapt in the wrong way. When the scapula sticks out, they try to adapt and they keep on hyperactivating the pectoralis minor. It makes their symptoms worse. So we do this combination for patients with long thoracic nerve. And for the right patient, they do very, very well. Number one, from the pec minor release, the strong adaptation will get better. And number two, from the nerve decompression, they may allow the nerve to recover faster. And we have a number of these patients that I'm pretty pleased about them. The spinal accessory is more tricky because usually when it shuts down, because of its anatomy, is much more tricky to try to decompress it and really expect a good outcome. However, in the setting, again, if you have penetrating injury, it's a great thing to do, to go in and explore and repair But in the setting of inflammatory, like Parsonage-Turner syndrome, it's very tricky where the lesion is to try to do anything for it. We can still potentially, we still do arthroscopic spinal accessory nerve decompression, but the outcome may not be as good. From this, though, when we talk about pain around this periscapular area, we have 3 areas that cause pain: lateral, long thoracic, medial to the scapula. Everyone thinks it's synaptic scapular syndrome. It's not only synaptic scapular syndrome. The synaptic scapula is most of the time one area. You can localize it, you can touch it, it's tender, and the patient snaps. When they have the pain along the medial border of the scapula, this is a dorsoscapular nerve. And sometimes can go slightly more medial and higher, which is spinal accessory nerve. And we can perform arthroscopic decompression of these nerves. And believe it or not, we have a quite good outcome with these, specifically with the long thoracic nerve.
How do you diagnose that problem?
That is excellent. This is when, like, again, over time, we are trying to make sure the patient gets used to the clinical diagnosis, not the imaging and EMG, because doctors and patients want to see something. If you tell them you have arthritis, look at your shoulder. If you have rotator cuff, you can show them the rotator cuff. Nerve injury, you can show them EMG. But when you have a pain syndrome, this is when it becomes much, much more tricky. But every patient, we try to explain this to them and we tell them it is very hard sometimes for patients and the doctors to talk about the problem that you can only diagnose it clinically. So let's give an example, lateral chest pain. Some patients, they have lateral chest pain. Now, both of you know what is on the lateral chest. If you think about it anatomically and everything, what do you have? Skin, serratus, long thoracic nerve, ribs, and lung. So if the lung and ribs are okay, which usually they are because you don't have symptoms from them or you know by imaging there's nothing, the only reason for the pain when you have someone lateral chest pain and you can go around the long thoracic, you touch it from up and down, they feel tenderness around this area. For me, this is it. Like this is a long thoracic nerve compression. It's almost like carpal tunnel, like cubital tunnel, radial tunnel, pronator syndrome. They're all similar. And many times we send them for diagnostic lidocaine injection. And believe it or not, whether it's placebo or not, I don't know. They feel, oh yeah, we felt half an hour, the pain was gone. So this is how I make the diagnosis. And in general, there is nothing that refer to the lateral chest along from proximal to medial. If you have only around the intercostals, yeah, you can have intercostal neuralgia, which is a different problem. But when you have something coming from proximal to distal along the long thoracic nerve, there is nothing, in my opinion, pathologically that can mimic this specific pain except that nerve. Now it becomes much more tricky on the medial scapula because there are so many things can cause the pain. Synaptic scapular syndrome, in my opinion, is very localized. And if you have it right, the patient does superb by doing decompression. But if you have pain along the medial border of the scapula where we know the dorsoscapular nerve is, this pain can come from pathology of the scapula itself. We've seen it in less than maybe 5% when we found elastofibroma or small tumor. It could be cervical spine pathology, thoracic spine pathology, or sometimes even rhomboid pathology can cause this, like rhomboid tear. Rhomboid tear, in general, they're more localized. But when we have this medial from proximal to distal, usually we do cervical and thoracic spine MRI and scapular MRI, always. The main reason just to rule out, not because I know there's something, just to rule out another reason for this pain. If these are clear, then we send the patient for diagnostic injection. And again, the majority of them, they respond very, very well to the lidocaine injection. And for us, will be a dorsoscapular nerve entrapment. So it is sometimes diagnosis by exclusion, even though it is direct. With more you see them, the more you can start to get them. And believe it or not, patients now, they come to you, they tell you, I think I have dorsoscapular nerve entrapment. I read about it. This is exactly what I have. But you have to do the workup correctly. The lateral chest pain one is easier because if the chest is negative and you have that pain, it's long thoracic nerve until it's proven otherwise. We send them for diagnostic injection. So this is more a clinical diagnosis with diagnostic injection and ruling out other pathologies causing this pain.
That's phenomenal. Let's get back to scapulothoracic abnormal motion. You talked at the beginning, you talked to us about the combined category. That's the last one. And I'm assuming a lot of those patients are kind of in the fascioscapular hemodystrophy category. Tell us, are there tendon transfers for those patients, or for those patients when you have that kind of combined deficiency, are you saying this is those patients largely should be treated with fusions?
That's an excellent question as well, and very tricky question, because when you have a combined deficiency, rarely ever it is an isolated phenomenon where you have patients that have both serratus and trapezius. Extremely uncommon. I've seen it, but extremely uncommon. FSHD is almost always bilateral. Many times they're different on one side. Like they rarely, at certain stage, they're really exactly the same. Many times we diagnose them in the clinic. Unfortunately, with the patient, they come without the diagnosis. And we give them the diagnosis and they go read about it. And unfortunately, on the web, they put the worst thing ever, which makes me feel very bad. So now I warn the patient, please don't read much of the web. And I try to explain to them what's FSHD, facioscapular hemodystrophy. So in general, it depends the age when they present, how long it has been, how is it on the right, how is it on the left. They can come at different stages. Many times they come with one shoulder looks hiking up, and they do EMG, does not show by the way by EMG, because they can get still some muscle stimulation and they think the muscle is okay. Or if the muscle is completely shut down, they get to the needle of the EMG through the muscle to the next muscle. They feel good contraction. They think the muscle is normal. But many times when these patients come to clinic and you have one shoulder looks okay, but when you examine it, the trapezius is weak, the serratus is weak, the other one is really pathologic. When it is both muscles are pathologic, the best treatment is scapulothoracic fusion. The tricky part is when you have the diagnosis of FSHD and the patient comes, many times they have either the trapezius completely shut, the serratus is still working, or vice versa. This is when it becomes tricky. This is when you can still do muscle transfer. However, you cannot predict with certainty the reliability of the transfer because we do not know when these muscles are going to degenerate. The patient with FSHD, they become very knowledgeable. They read a lot about the topic. So when you try to explain this to them, they understand very well. Anytime when I have patients with FSHD, and if they have both muscles, scapula big time, winging off the chest wall, ST fusion, they do excellent. When I have only one muscle mostly affected, and I explain to them that we can potentially do muscle transfer, however, we don't know if this one will last you a year, 2 or 5 or less. None of the patients elected to do muscle transfer, believe it or not, even though I gave them that option, but because it is not reliable. So yes, my friend, like the single most reliable option for these patients is ST fusion, and they do really very, very well. And we publish about a large number, like probably the largest number in the literature about ST fusion for FSHD. Their healing rate is excellent. They do very, very well. It's long lasting. And very important, we were able to demonstrate, different than others, that we did not need iliac crest, and many times we did not even need bone graft, and they still did well.
Yeah, this is a fantastic body of experience. And I wanted to touch on another area where you definitely have a unique area of expertise, and that's around scapuloplexy. I know you do this in specific circumstances. When are you doing this, and what's that ideal patient look like?
Well, so we started the beginning of this talk about when we look at the scapula, how do you diagnose, or how do you look, how do you inspect, and then what kind of diagnostic testing. And then we talked about with the exam, anytime the patient comes with a STAM, now we understand STAM, scapulothoracic abnormal motion, anytime patient comes with a STAM, 2 big categories, structural, functional. Now, functional, it means based on exam. So let's say patient already, and usually when they come here, they already have their imaging. They're already frustrated. They've seen many doctors. They told me potentially I have long thoracic, but one EMG was positive, one negative. So they come, you examine them. There are specific tests, we can talk about them if you want, how to make sure the serratus is working well, the trapezius is working well. And you examine each muscle individually, and they look perfect. But when you examine the patient can barely move, and the scapula hike big time as if the patient has almost FSHD. But in reality, each muscle is normal. So when each muscle is normal, but together they're not. In a way, they are exhibiting this big stem. This is what we call a functional stem. Functional stem, it means, as it sounds, functional. It means there is no structural abnormality. So what do we need to do? We try to reverse whatever mechanics led to this functional abnormality. So usually what I tell the patient, this is what I do in meetings, by the way, and even both of you right now in this meeting, even though this is on the phone, I tell you, raise your right hand up. Whether you're doing it or not, you raise up and down. I tell you, even though both of you are very intellectual, you're very smart, tell me how you raise your arm. You tell me, you think about it for a minute, by the way. When I ask you, how did you raise your arm? You'll think about it for a second. It's like, oh, nobody asked me. Well, I thought about it. I did it. I told you, I know, I will tell you, I know yourself know that in this 1 second or 2 seconds, your brain gave order to 8 muscles in a row to exhibit the motion. It's not you. You think about it for a second, it's like, oh, I never thought about it this way. Let me put it for you in a slightly tricky way. I will tell you right now, you're a shoulder surgeon. I'll tell you, go ahead, activate your supraspinatus. You think about it for a second. You say, in your mind, you want to do job test. Tell me, no, job test, you're trying to examine this muscle. I want you to isolate it, just the muscle supraspinatus. I want you to activate it right now. Can you? You can't. You can't. You can raise your arm. You can try to trick a job test. You cannot. You can see the pec. You can activate pec. You can see the lat. You can activate the lat. Serratus, you cannot. You move it, but you don't see it. Supraspinatus, you cannot do it. You can do it indirectly. So what I'm trying to say is there are a lot of things we think we control, but we don't. We control the order for it to happen, but we do not control it ourselves. So when this order goes out of control, whether what is subconscious, subclinical, psychological, whatever you want to call it, you end up in a functional problem. And why I'm saying all of this, because in a functional problem, now the brain is giving the wrong orders and the scapula is going out. Hyperactivation of the pec minor, which can tilt the scapula up. The upper trapezius can hyperactivate. It will make it worse. They learn how to hypoactivate the serratus. And now you have, quote unquote, winging or stem similar to serratus paralysis. So how am I going to fix it? I'm going to do pec major transfer on this one? It's a mistake. The muscle is normal. So what we try to do, we try to keep or position the scapula on the chest wall and force it to be where it is so that over time, the brain will reanimate it correctly to go back to where it was supposed to be. So by removing a culprit, which is pec minor, which is, we can release every pec minor, even in a normal person, it will not cause a single problem, which is so this is okay. And we tie the scapula on the chest. We'll call it pexy, sexy pexy. In fact, the patient likes the sexy pexy more as a term, which is essentially releasing a culprit muscle that should not cause any problem if you release it, which is a pec minor. And you tie the distal scapula on one of the ribs to force it to stay where it is so that when this abnormal motion wants to start, the brain says, hey, I cannot do it. Okay, let's see, maybe I can reanimate it, and boom. So you're essentially doing the surgery to affect the neuroplasticity. It's not traditional, it's not classic, it's not something in our literature because we are used to structure problem and fix a structural problem. But this is unfortunately how we can fix the functional problem by doing surgery like this.
That's a great explanation for why it makes sense. And I think every shoulder surgeon who's in practice has seen this patient. So it's not an uncommon problem. And I think your way of explaining it to say it's very hard actually to fix abnormal firing of motion that you don't consciously control. Here's my question for you, and this is the part that I just have never quite understood. We do see patients who start to develop down this pathway, who go to therapy, who get better. Like I've definitely seen patients where they've done physical therapy, it's resolved the problem. The idea behind the scapulopexy is it gives them hopefully a better opportunity, to go back to therapy and fix the problem. So I guess my main question is or maybe it's really twofold. Number one, how much therapy or how good of therapy does the patient have to do before you'll say, okay, it's time for us to do the scapulopexy? And then number two, what does the post-op protocol look like? Or is there specific things you're doing post-operatively to try and, rewire the patient's cerebellum to get their serratus and their trapezius
Yeah.
and their cuff to fire in the right sequence? Like, how do you fix that?
Yeah. So again, this is great, by the way, because this is our daily daily work. This is exactly what you're talking about with patient explaining everything the same. But this is a tricky part. You're asking these questions because, again, if you look at, you're an orthopedic surgeon, I'm an orthopedic shoulder surgeon. We're not used to functional problem. And at the same time, specifically, we're not used to treat functional problem because we are there to fix structure. We did what we did to fix a fracture, rotator cuff, instability, nerve injuries. But when it's functional, you feel like, but this is not my job. In reality, it is, because you're going to help this next, like if the therapist or physical therapist or psychotherapist could not help, you can help them. However, this is a deal. Every patient comes, so your question is great because this is the next layers that we're talking about. The treatment you're talking about depends on what type of stem. So as you know, the stem, the functional stem, now since we talk about structural versus functional, the functional itself, there are multiple types. From the functional perspective, we have 4 types. Type 1, 2A, 2B, 3, 4A, 4B. And believe it or not, when I did them, I thought about them as severity. Like, I think this one more severe than this one, this is why I put them this way. And then I realized over time that the patient can progress, in fact, from 1 to 2 to A to 2B to 3, which is amazing. I did not even know that, which was a happy kind of coincidence or surprise. But anyway, so depending on the type of the stem, depending on how long this has been going for, extremely important. I have patients who come, I rarely ever within a year, most of the time 2, 3, 4, 5, 7, 8, 10 years. The longer it is, and I know this is not us, but I will explain it. The longer it is, the more change is going to happen at the level of the brain, amygdala, and other areas that will become lit up. The difference between the brain being lit up and between the shoulder being inflamed, for example, you can give an anti-inflammatory, you can shut down the inflammation in 1, 2, 3 days. When the brain area is lit up, it will take months to reverse. And this is now we're trying to work on functional MRI to try to determine this area that's lit in the brain, and we'll see what we can do to improve it. Now, so since we are talking about a non-classic problem, a functional, by definition, a regular therapy is not going to work because this is not structural. We're not trying to fix a structural problem. And physical therapy, you do it 1, 2, 3 times per week. So that 1 hour per week, 1 hour per day, you still have 23 hours for the patient to go back to where they were, and you have the rest of the week. So you need something in continuous more. The regular therapy will not usually work on it, except it's very, very early on. So in general, when patient comes, regardless now, before when they come, let's say a year after, let's say they have the symptom for a year or 2, I usually jump immediately to explain to them functional, structural, and why we do this axipexy or others. But now, almost every patient, I'll give them the benefit of the doubt, and we do 3 things to these patients. We do a Botox to the pec minor, again, is one of the culprit. I'm going to try to weaken their shoulder, but I don't want to eject the trapezius or do anything else. I prescribe the shoulder pacemaker. I will talk about it in a second. And sport psychotherapy, not a physical therapist, sport psychotherapist. And they can do therapy if they want to. But you need something continuous to help them. Botox can shut down the muscle will stay shut down, it can help. The shoulder pacemaker, I'm not still with the company. I know I may work with them, but I'm not working with them right now. But Philip Moroder talked about it for patients who have stem and instability. In my patient, it does not work as much. But the best part about the shoulder pacemaker, if you know, so the shoulder pacemaker, you have a band, you put it on your arm. You can look at your avatar. When you try to move your arm, it senses the motion, and then you have patches around certain muscles that you put them around in order to activate these muscles. So whenever you move your arm, that patch senses your motion and sends stimulation and forces this muscle to work. Now, what's the advantage of this one for me? You can use it several hours per day, every single day. Now you are stimulating the brain nonstop. Now you're affecting the neuroplasticity. So I do the 3 things. And psychotherapists are much better than me and both of you to try to explain how you can connect the brain to the shoulder because it's not our expertise. So we give them this chance. Now, what's the percentage of patients that I gave them this protocol and they got better? If I don't want to say 0%, I would say maybe 5%. So 95% failed it. But you already started a protocol that work on the neuroplasticity of the brain that if you want to continue after surgery, it will affect and have much better impact. So this is for the therapy perspective of it. And now let's say we'll give this example. We gave this protocol, patient came back, yeah, I did not feel much improvement. I felt a little bit better when we put the shoulder pacemaker, but every time I take it out, it goes back. Okay, well, all right, we'll talk about sexipexy. They understand the concept. You do it. Now, after surgery, even though the sexipexy is meant just to stabilize the scapula on the chest, you can essentially move them immediately. However, we intentionally don't. We keep the shoulder still for 6 weeks. We tell them no motion whatsoever. Why? You want the brain to forget that pattern that was before. And then when they start therapy, I talk to the therapist myself. You got to teach them almost how to walk again. Little by little, retract the scapula, a little bit of motion. If you feel the scapula taking a different course, go down and go back again. But now the pexy is holding the scapula down. So even if the brain wants to go back, now because you let the brain rest for 6 weeks, and you try to move that arm up, the scapula cannot stick up because of the pexy, because of the stabilization. Now we're activating the right muscle and get back on track. So in patient with stamp 2A, for example, the success rate of this is 85%. But when the higher the stamp, it becomes harder. But this is a quick overview. This is a huge topic, but this is a quick overview.
Awesome. That's an incredible framework to appreciate and understand this, and we appreciate you pioneering in this front. One additional area, if I can implore you for 5 more minutes, I'm going to go back to our safe space, our traumatic injuries. And one of the entities that I have an interest in is this concept of rhomboid injuries, be it tendon avulsions or intramuscular injuries. Can you just talk to us briefly about your experience for that? What the patient looks like, any diagnostic tools, and then ultimately your approach for treatment?
Yeah, you're nailing all these challenging questions.
Thank
This
you.
is also these are all the tricks. So the rhomboid tear is a very, very tricky concept, by the way. It has been published about muscle dehiscence or muscle detachment. And in my patient collection and data, the only time I've seen dehiscence is after iatrogenic, like someone had a surgery and dehisced. What I have seen is muscle thinning. Like, let's say they tell you there's a specific trauma, young patient. Let's talk about the not tricky one. We'll talk about the tricky one in a bit if we have time, because I think we might be running out of time. But let's talk about the clear. Young patient, someone in the 20s, they tell you specifically they were doing something, they felt a snap, and they have a pain, and they can localize it with one finger around the medial aspect of the scapula. If you do MRI on the spot, you may find some edema in the muscle belly. But if you do it later, it's going to be normal. I have not seen a single rhomboid tear that showed on the MRI, except if it was done acutely. That's number one. Number two, I already spoke to you about that these muscles, they don't have tendon. So there's one time, in order to prove my point, we were doing a patient, it was not a tumor, it was someone need the fusion. There's a combined trapezius and serratus paralysis, and the patient need the fusion. So usually you detach the rhomboid completely and you do the fusion, etc. But these muscles are still working, but the trapezius serratus are not. So what I did, instead of detaching it, I put a suture, and I asked the patient if I can do that. The patient was okay with that. I put a suture on the muscle, on the rhomboid, and I sutured in a way, and I created a very quick traction on the muscle, like something that will cause tear. And where did the tear happen? In the belly of the muscle. It's almost, I do not know. It's like it will perplex me how it could be detached from the scapula itself. It could, but I haven't seen it except in iatrogenic. So I try to initiate it even myself. I try to do it in live, living, not even in vitro. And I could not tear the attachment because, again, that attachment of the rhomboid is the confluence of the rhomboid major, the subscap, and the serratus. They're the three of them on the same medial border of the scapula. So why am I saying this? Because when we diagnose rhomboid tear, it's usually in the belly of the muscle, which means it's only thinning of the muscle. I've done more than 60 or 70 of these. The only reason I did not publish about it, because it's very hard for me to demonstrate that there is a tear because it's a thinning. So, and what do you do for thinning? You cannot repair the thinning. We'll do advancement with trapezius advancement. We'll talk about it in a second. The diagnosis, though, is very, very tricky because it's rarely demonstrates, and you can see it on MRI, except, again, acutely. So now you're talking about the same thing that we were talking about before. Now you have a problem that you cannot, even though it's structural, but you cannot demonstrate on imaging. Patients are young, and you're talking about if you want to do repair or something, it's going to take a long time to recover. So anyway, in general, young patient, but this is where the tricky going to be part about it. If they are young, traumatic injury localized to one area. And if this area close to the scapula, that's rhomboid tear until it's proven otherwise. If it is in the mid aspect of the rhomboid, it could be rhomboid tear or localized entrapment of the dorsoscapular nerve or both. This is where it becomes tricky. How can we diagnose it? Honestly, it's almost impossible. It's almost like if you have someone who has arthritis with rotator cuff tear. If you ask the patient, do I have the pain from the arthritis or from the rotator cuff? It's impossible to answer. Sometimes you feel if the pain is posterior, it's more arthritis, but in reality, you cannot. Because you have rotator cuff and arthritis combined, it's really hard to know where the pain is coming from truly. This is very, very similar. And believe it or not, among the patients I have this specific scenario, I had at least 8 medical professionals, between urologists, OBGYN, etc. They have this problem. And usually this is what I do with these because it's very, very tricky to diagnose because imaging will not show anything. We ruled out cervical thoracic spine pathology and there's nothing in the scapula. It's localized pain. They did well with localized injection. And this will become very tricky. So these patients, this is what I say. I say we can go in arthroscopy. We did one yesterday, in fact, arthroscopically. And I usually mark the area of the pain and look at the area, what's going on. The patient I did yesterday, for example, he has a significant inflammation, thickening of scapulothoracic bursa, and I was able to localize completely dorsoscapular nerve, and it has a lot of junk around it. So this is a patient, I know with certainty that the dorsoscapular nerve entrapment has to do something with it. But we have to see how to do after surgery. But if this patient came and he say, my pain is resolved, we're done. But if he came and he said like, yeah, I feel like my pain only 20%. So now we go back and repair the rhomboid. This is why it's very, very tricky topic. And now I changed because I changed even my practice about it because of this element of potential rhomboid and dorsoscapular nerve pathology happening at the same time. But there is, other than diagnostic injection and examination, I rarely get them on imaging. And we're talking about very, very tricky topics. The easiest was when we talk about trapezius, triple transfer, because structural, this is a treatment, serratus, etc. But once we get into the functional aspect and you talk about something that you cannot diagnose by imaging, it becomes very tricky.
I think these things are very challenging, and I think that your kind of clear-sighted way of laying them out. And again, I appreciate you going through a huge amount. We could have had an entire podcast about any one of these topics. So your experience, your clear-sighted way of thinking about them, obviously the courage it's taken you to really innovate and pioneer many of these areas that I think a lot of things have seen us, and I think doctors have traditionally just said, well, there's nothing that can be done, or we don't know what the problem is, so there's nothing to do. And I appreciate everything you've done to try and push us forward in this area, and I'm sure that all of our patients will benefit from the doctors that listen to this podcast and hopefully approach these patients with a new way of looking at these problems. So I thank you again. It's really helpful for us to have you as a guest.
Thank you very much, and I appreciate having me.
Awesome, incredible, really fantastic comments. I'm going to go back and listen to this. I certainly regret not having that second cup of coffee before this morning, but we are so appreciative of you.
No problem. Well, have a great day. Thank you again for having me, and we'll see you hopefully soon. Okay? Cheers.
Thank you, my friend. Well, that's about all the time we have available for this episode. We just want to offer a big thank you to you for being our guests, and for all our shoulder and elbow listeners out there. Don't forget to subscribe, and we'll see you next time.